everyone, welcome to our YouTube channel where we discuss research papers in our fields of interest. We are Laura Bourget
and Laura Alvarez, and we're going to discuss a very interesting article today with all of you. For today's video, we thought of discussing the selection of the statistical test on a paper done on the effects of fecal microbiota transplantation or FMT on 8-week remission in patients with ulcerative colitis.
The question in this randomized clinical trial was, can a short duration of fecal microbiota transplantation using anaerobically prepared pool stool suspension induce remission in active ulcerative colitis?
You know, this is a very innovative topic, and as we well know, ulcerative colitis is increasing worldwide, and it has a high rate of relapse, as discussed in an article published in the Journal of Gastroenterology titled Ulcerative Colitis Patient Characteristics May Predict 10-Year Disease Recurrence in an European-Wide Population-Based Cohort. One of the reasons they decided this was a relevant topic to navigate and study was that FMT has demonstrated variable efficacy in treating ulcerative colitis in 3 randomized clinical trials while using aerobically prepared stool suspensions with high treatment intensities.
Surely, FMT has shown potential to be the therapy for many other diseases who are influenced by alterations in the microbiome. Proposing FMT as treatment for UC through the modifications of the colonic ecosystem seems innovative and could potentially transform the way we treat and view UC.
Especially with the study we brought today, we wanted to focus on the statistical test the researchers chose.
The main objective of the study was to assess the efficacy of a short duration of FMT therapy to induce remission in UC using anaerobically prepared stools using a total of 73 adults who were diagnosed with mild to moderate active UC. The study was double-blinded, randomized in 3 Australian tertiary centers between 2013 and 2016 with a 12-month follow-up.
The patients were randomized. They either received anaerobically prepared pooled donor FMT or autologous biocolonoscopy. This was followed by 2 enemas over 7 days. At 8 weeks, the participants receiving autologous FMT were offered the therapy and they were followed at 12 months.
The primary outcome was a steroid-free remission of UC, which is defined as a total Mayo score of less than or equal to 2, with an endoscopy Mayo of 1 or less at 8 weeks. The steroid-free remission was reassessed at 12 months. Although much is left to discuss in this study, as we mentioned earlier, we are approaching the article from a statistical point of view. We will be discussing the statistical methods and sample size calculation and whether we consider the choices appropriate or not.
Now, we will discuss the parameters for sample size calculation for this study. They obtained a sample of 73 participants, calculated with an alpha value or significance level set at 5% and a power set at 80%. The effect size of having remission in UC is 34%. They obtain a minimal clinically relevant remission rate of 60%. The sample size calculation was based on previous active ulcerative colitis trials 1 and 2 called ACT1 and ACT2, and more information can be found in their protocol. However, when analyzing the sample size calculation, we noted that they didn't mention if they calculated their sample size considering the dropout rates from previous studies. Dropout rates are crucial for sample size calculation, mainly if the study includes a follow-up period. This is why we consider this is one of the limitations of the study. Moreover, there was a significant loss of follow-up at 12 months, and there were a total of 4 patients who withdrew from the study after being allocated to the study groups, 3 from the donor FMT and 1 from the autologous FMT due to complications of UC. Not considering the dropout rate could have led to an underpowered study, and that is why for future studies we must take into consideration the dropout rates.
Following the sample size calculation, we will discuss the statistical methods. Here in Table 1, we can view the different variables evaluated in the study. Reviewing Table 1 of any paper is primordial and can help you have an overall view of what to expect and which choices you will take given the different variables. First of all, identifying the methods of central tendency in the study is key. An article published in the NIH in 2011 defined measures of central tendency as a statistical measure that identifies a single value as a representation of an entire distribution. This basically aims to provide an accurate description of the data. In this study, they used the mean, as we can see here. Another point to consider is the dispersion of the data. As explained in Professors Felipe Fregni and Ben Illigan's book titled Critical Thinking in Clinical Research, the measures of dispersion are necessary for a more thorough description of the data, which helps us to complement the measures of central tendency. We can view here interquartile range and the standard deviation. The interquartile range represents 50% of the data, and the standard deviation basically describes the variability of the data around the mean.
For the primary outcome, they wanted to compare both groups with steroid-free remission of ulcerative colitis. This was modeled as a binary categorical variable. That is, steroid-free remission was labeled as a total Mayo score less or equal to 2 in a range of 0 to 12, with an endoscopic Mayo score of less than or equal to 1 at week 8. The authors employed a Fisher exact test to analyze differences in proportion of the primary outcome, which is steroid-free remission of UC across treatment groups, donated FMT versus autologous FMT. But why did they choose the Fisher exact test and not chi-square test? Chi-square test is sensitive to sample size and small expected frequencies. Pearson's chi-square test is often employed to assess differences in proportions in categorical variables across two or more groups. Usually, chi-square test of proportion is utilized when values or frequencies in most cells in a contingency table are more than 10. On the other hand, Fisher exact test helps analyze differences in frequencies across cells that have smaller numbers. Fisher exact test is often employed when 20% of the cells across contingency tables have values or frequencies less or equal to 10, or sometimes authors consider less or equal to 5. A post hoc linear mixed effects logistic regression estimated the effect size of treatment with donor FMT on primary outcome, steroid-free remission. In Table 2, we can see that in comparison to autologous FMT, treatment with donor FMT was associated with 5 times higher odds of steroid-free remission, like a 400% higher chances, like an odds ratio with 5 with a 95% confidence interval between 1.2 and 20.1, with a p-value of 0.03, making it statistical significant compared to autologous FMT. The regression model was basically applied to the primary outcome to estimate the effect size of treatment, that is, the likelihood of achieving the primary outcome via one treatment arm with reference to the other. Another statistical test used by the researchers was the Mann-Whitney-Wilcoxon test to compare autologous and donated FMT, and the variables were baseline levels of butyrate and dietary fiber. Wilcoxon-Whitney-Wilcoxon test compares numerical or continuous variables between two groups, autologous versus donated FMT, with a non-normal distribution. As you can see in Table 1, the diet, as they specified as butyrate and dietary diet, are indeed continuous variables, but are not balanced. We assume they opt to a more conservative method since they couldn't use the central limit theorem due to the relatively small sample size. They don't explain why they choose the Mann-Whitney-Wilcoxon test instead of a parametric test like a Pearson pair t-test.
In the following image, we want to portray the results between autologous FMT and donor FMT. Here we can view the comparisons of the total Mayo score in both groups, the baseline score and the score at 8 weeks. In addition to looking at the changes in Mayo score as a group, we were also able to look at each patient's response based on the treatment. Now, the box plots of the baseline and at 8 weeks per treatment group are viewed here. We can see a great difference after 8 weeks in the donor FMT group. However, there was almost no change in the autologous FMT group. Therefore, we can conclude that the selection of the mentioned statistical tests were appropriate for this randomized clinical trial. The statistical test chosen to evaluate both the primary and the secondary outcomes were appropriate, given the description of the variables and the questions being assessed. The use of non-parametric tests was adequate since the assumptions were not met for parametric tests. Some of the assumptions for parametric tests are that it needs to be normally distributed, there must be homogeneity of variance, and continuous variables. In this case, it wasn't met for the reasons we previously mentioned. However, we met the assumptions for non-parametric tests, which are met when the assumptions for parametric tests are met. The sample size is relatively small, and the data is either nominal or ordinal.
Since it was a crossover design, they stated that didn't have a pre-specified antibiotic washout period prior to the study entry, so there is a possibility that participants took antibiotics before the trial, which might bias the initial microbial assessment. This study wasn't powered to assess safety. Therefore, they recommend that larger studies be conducted to evaluate this. Another concern or observation was that it was hard to assume why they chose a non-parametric test without specifying if they tested for normality using continuous data. As this was one of the first studies done to assess the efficacy of FMT in patients with ulcerative colitis, there were many limitations. However, we believe this study opened the grounds for many other large studies which are being conducted currently to assess the efficacy of FMT in UC.
We certainly value the transparency of the researchers in this study and the explanation for their limitations. Thank you for watching our first video discussing statistical tests.
We hope you learned from our analysis, and we welcome any opinions and suggestions in the comment section below. Thank you.